processes of a new variety, which have been unfolding in a sense behind our backs, or I mean, we see their manifestations every day, but we often don't know what is actually the cause behind this, or what are the dynamics going on, behind all these processes. So that's why probably we need to discuss those. And of course, the questions asked last time were very insightful. They were important questions. So mainly I have a presentation which mainly tries to not just answer, but in a broader sense, address some of the questions that were raised last time, and to go deeper into the topic with more examples and more specificities.
Sure. Gayatri has a bit of a cough today, but otherwise she would be the one telling you that we had some really positive feedback from last session. Okay. A lot of people really enjoyed it, and people are watching it on YouTube as well. So we're really hearing good things. Okay, it was very positive. But anyway, I think it's 6:36, so maybe we should kick off the session today. Yeah. Okay. All right. Great. So thank you so much, all of you who are here. This is the second session of the Unpacking the Healthcare Ecosystem series. It's being hosted by the Forum for Equity for Health and also the Barefoot Academy of Governance together. Although FEH, Forum for Equity in Health, is the primary. So we hope you attended the last session, but even if you didn't, no problems. The link is up on YouTube. We'll also share a link to a Google Drive where you can see, where you can have some readings, and you can also, the recording is also freely available there. We, just like the last session, we hope that these sessions will continue to be quite interactive. So please, I think I can speak on behalf of Dr. Abhay and Indira that feel free to bombard with your questions. We encourage as many of them as possible. There's nothing is foolish, nothing is beyond the scope. Please, by all means, just pose your questions. Yeah. The Forum for Equity in Health, very briefly, is a collective of medical professionals from very diverse backgrounds across India who came together to attend a workshop called Govern H, with H standing for health. And this workshop, we have 4 in the series, and we just completed the 3rd one last week at this lovely little valley called Sithilingi in Tamil Nadu. So it is an attempt to explore healthcare, but also health in a far more broader way, understanding the political dimensions of health, understanding it in all of its different components, right? Dr. Abhay here, very briefly, a lot of us know him already, but he is a public health physician. He's been working on community and public health issues for the last 3 decades. Dr. Shukla?
Yeah.
Is it? That's a very long time. He's a well-known health activist. And you just Google him, you have a list of his accomplishments. But I think for me, from his profile, what I found most interesting as a non-doctor, and maybe one of the few in this session, is his work on the Patient's Health Charter. Because the Patient's Rights Charter, I'm sorry, because it's not very often that we talk about patients' rights as much in India. And so it intrigued me a lot. And I don't know, I've lost count of how many of his sessions I've attended. He's always very engaging and compelling. And today we have Indira also with us. So Dr. Abhay, over to you right away. I think we'll have a bit of a presentation right at the beginning, and then we'll have a few questions. So for those of you who are new, keep in mind that we had a few questions posed in last session. So we'll be addressing some of those questions at the end of the presentation, and then we'll go to the second part of today. Yeah, is that fair, Dr. Abhay?
Yeah, actually what Indira is here as a discussant, and she is very knowledgeable, and she's done a lot of research on these issues. So after my presentation, I think it will be good to request Indira to add some points as in one round, and then maybe we can open it for discussion. So Indira, is that okay?
Yeah, okay.
Yeah.
We'll see how it goes. I mean, if you if I don't need to add, then I could also keep responding to the questions as they
Yeah.
come. And thanks, Shyam. I think the only limitation may be that I may not be able to respond to all the questions. I will try my best, and I'm also learning in this process. Actually, understanding what is happening. Anyway, it's good to
Yeah,
be
Indra is
here.
being a bit
Thanks.
modest, but
Yeah.
actually, at one level, it's true that all of us are learning.
Yeah.
So, the whole field is so vast and so complex that we're
Right.
all at different levels, grappling with these. So, I think I'll introduce Indra briefly so that, later on we can then go directly into this discussions. So, Indra is basically a senior public health researcher. She's a visiting faculty at B.R. Ambedkar University in Delhi, and she has a background in biochemistry and biotechnology, and she has done her PhD from JNU, and she has done quite a bit of research on the issue of medical technology in health, which is a very interesting area. And she has worked on a variety of issues, but among them, and she was part of Sathi for some period, and where we worked together, and she led a project dealing with corporatization of healthcare in India, particularly in Maharashtra. And so she has quite a bit of background on these issues. So, and she's also written on digitalization in the health sector. So I forward that article of hers, which is quite insightful about the National Digital Health Mission. So I think we'll now move into the presentation and session, further session. So just a minute, I'll put up my presentation.
And one small request, those of you who can, please do turn on your videos. We'd love to see you all as well, if your bandwidth and if it permits. Thank you.
Okay, so should I wait for the video for the videos, or should I go
No,
to the
no, you can go ahead. Thank you so much.
Okay, maybe at the end we can ask everybody to
Sure.
put on their videos. Okay. Okay, can you see this? Is it visible?
Yes, visible to me.
Okay. So as we just briefly talked, that this is a continuation. This is the second session in this series, and we'll be going into quite some depth about what actually is meant by financialization of healthcare in the Indian context. How is it different from other background major processes like privatization, commercialization of healthcare, and so on? And what are some of its features, and how is it actually, how do we understand it better? So first of all, I'd like to sort of start by saying that when we start discussing financialization, it's like opening a Pandora's box. And all of you, I think, might be knowing about the fable of Pandora. So she was told not to open this box. She was warned. But being a curious person, she opened it. And out of this box, all kinds of demons came out. And it was something really probably disturbing. And it was probably unexpected also. And after all these demons came out, there was no way she could put it back into the box. I mean, they just escaped from the box. But at the end of the process, there was also a gem at the bottom of the box. And that gem was called hope. So I think discussing financialization is a little bit like that. Once we go into the details, it looks as if a lot of, very, just a second, a lot of, well, let us say, overwhelming and maybe to some extent even disturbing kind of features emerge from this exploration. But at the end of this journey, I think there will be some hope. So with this, I'll move ahead. And one question which came up last time repeatedly, and which is a very valid and important question, because we have certain frameworks with which we approach the healthcare system. And privatization, commercialization, and even to some extent corporatization, these are well-known concepts, relatively well-known, I would say, at least in progressive health activist circles. Now, what is different about financialization? Why are we bringing in this new term, this new framework? And as I talked last time, I'm talking about a healthcare ecosystem, which is not just about healthcare, but also something broader. What is new about this? So let's go into this. But to understand this, we have to go a little bit back in history. And we have to look at the trajectory of evolution of the Indian healthcare system, at least since independence. So in the period since independence, in the initial period, the 1950s, 1960s, 1970s, what we had at that time was what I called socially embedded healthcare. So there were most of the hospitals at that time were public hospitals, and there were some charitable hospitals. There were practically no private hospitals at that time. But of course, there were individual private practitioners, and those are, of course, quite common. And many of them functioned as what we would now call family doctors, or even specialists. They were like individual practitioners, not having a very big setup or a huge capital investment, but they used to see patients. So the entire healthcare scenario at that time was more socially embedded, in the sense that whether it was public hospitals or charitable providers or individual family doctors, they used to work relatively close to their communities and had some kind of organic relationship with society in different ways. But after 1980s, the situation started changing, as we know, and healthcare started becoming a marketized commodity. And this is when we saw the rise of small and medium private hospitals, many doctor-run private hospitals, doctor couples, small groups of doctors, individual doctors setting up their private hospitals, setting up their nursing homes, and also some initial emerging of larger private hospitals. So now this was an important phase, and this is where we can say that the process of privatization and commercialization started. And of course, this was an important change, which actually created the basis for the next phase. And the next phase, which is from the 2000s onwards, is when healthcare started becoming a financialized industry. And instead of being a social institution, it became more and more of a profit-making and finance-driven industry, where the goal, instead of fulfilling people's health needs, started becoming more and more of very much focus on profit maximization. And this is the period in which we see the rise of large private multi-speciality hospitals, the rise of corporate healthcare. And corporate healthcare is broader than just corporate hospitals. It also includes corporate diagnostic chains, imaging centers, and also a variety of other associated kind of providers. And this is the phase that now we are in. And so there is a background to the financialization of healthcare. And to put it briefly, the privatization and commodification or commercialization of healthcare since the 1980s and 90s has created the basis for now financialization of healthcare. So this is a kind of a journey that we have seen, particularly since the 1980s, since the last roughly 40-50 years. So privatization and commercialization of healthcare are important concepts which we continue to use. And these have created the basis subsequently for large-scale financialization. Very strictly speaking, even in the 1980s and 90s, there was certain, of course, operation of finance, but the role of financial actors in a dominant and significant manner was not prominent at that time. And as I had mentioned in the last session, that the definition of financialization is a major role of financial actors, financial processes, and financial institutions in the entire sector. And that is something which has picked up subsequently since the 2000s, roughly. So there is continuity and there is a connection between privatization and financialization. But the current phase of financialization may be viewed as a distinctive phase within the evolution of capitalism, and including the evolution of capitalism in healthcare or medical capitalism. So let's see what in the previous phase, what we are talking about is basically 1980s, 1990s. So there were healthcare providers. There, of course, there was a great increase in the number of private healthcare providers, as I've already mentioned. private small and medium hospitals, nursing homes, and also um, uh, other kinds of individual practitioners continued, but they were financed through banks, often nationalized banks. Many set up their own hospitals through self savings, family savings. This is when the doctor entrepreneurs started, doctors setting up through their own family or whatever funds, with maybe some loans being taken. Government subsidies also played some role, especially for what we call now charitable hospitals, which receive free land or very heavily subsidized land and other kinds of incentives. And NRI funds also started coming in. So these are what I call the traditional sources of financing. Now, these sources of financing, it was not like the cart leading the horse. So the horse was the healthcare provider and the cart was behind it, the financing, which was sort of facilitating their growth. Um, and healthcare users also at that stage were, health insurance had just started, and it was only probably sections of the middle class, the upper middle class, which had some access to voluntary health insurance. Most people were not covered by insurance, and healthcare seeking was based on trust to a large extent. So people used to search out or seek out a hospital or approach a doctor or a hospital whom they knew directly or indirectly through family contacts, through word of mouth, through friends and relatives, that okay, ये doctor अच्छे हैं, ये hospital ठीक है. And doctor to doctor referrals were also a dominant mode or an important mode. So we see that in all these cases, financing was, of course, no such system can work without financing, but the nature of financing was in a sense more supportive or subordinate, and basically that is what we saw in the earlier phase. Now what has changed? What has changed is, in the current phase, we have a whole range of powerful, highly influential and globalized financial institutions which have entered the picture in a very major way. We have development financing institutions, which I'll talk about shortly after this, which are international government-supported bodies, supported by the governments in developed countries. We have large-scale private equity firms who are not concerned particularly about healthcare. They will invest wherever they get a maximization of their return. We have venture capital, which perhaps you may have heard about, which is a peculiar and special kind of capital, which seeks out innovative, startups, etc., where very high rates of return are expected. Of course, there is a risk also involved, but they seek out very high rates of return. Multinational corporations also especially in the medical equipment and pharma industry, and also large-scale domestic corporates from within India. All of these financial institutions, and also along with them, what we will call financial intermediaries, which in a simple term you can call financial middlemen, they entered into the picture, and they have been growing, and their influence has been growing more and more in the recent period. And these financial institutions, which are at the center of the process of financialization, they acquired a major stake in these healthcare providers, basically in hospitals or imaging centers or diagnostic centers or even other kinds of. So, and because these are large scale institutions which have large scale finance through which they want to invest and also recover their high scales of profits, they prefer large institutions like corporates. They are not interested in funding some small or medium-sized private hospital in some tier 3 city. So they have very much concentrated on corporate healthcare, and they have accelerated and heavily actually promoted corporate healthcare to corporate hospitals in India. So we all know about corporate healthcare, but we perhaps don't know as much as about the financial institutions which have been driving this entire process of corporatization. And that is important to understand this linkage. On the other hand, as far as healthcare users are concerned, they have been converted more and more into consumers, and they also have been, their healthcare seeking has also been financialized because they are covered more by insurance, more and more. So the upper middle class having voluntary health insurance, and poorer sections of the population being offered or being given a government-supported health insurance through various schemes like PMJY and various state-specific schemes. So we see that finance starts entering into circuits of, reproduction of different parts of the system. And that's why it starts forming a new kind of ecosystem where finance is everywhere. And what I called last time, financialization of everything, including even the referrals. So now instead of trust being the basis on which a patient gets, lands up in a particular hospital, and now it is commission driven more and more. And many of you who are practicing doctors will know this very well, that how, small individual practitioners and, family doctors and so on, they are part of a chain which, is involved in commission-based referrals, and they channelize patients to some of these larger and even corporate hospitals, and then get a cut or a commission in return. And so the whole healthcare seeking behavior also gets more financialized rather than being socially embedded and trust-based. So to put it briefly, if somebody's mic is on, please put off your mic. Please mute yourself. So what is different about this phase? Of course, it's a phase which has built upon the previous phase of privatization and commercialization, but three important distinguishing factors: new actors, newer processes, and emerging features and impacts. So I'll briefly try to talk about each of these three, because last time we did not go into these details, but of course it's quite important that we understand this. Otherwise, we will not be able to understand the key the novelty and also the significance of financialization. Now, who are these new or newer actors? 20 years back, 30 years back, when we used to talk about how do developed countries, basically deal with, developing countries, there used to be aid. And there used to be all different kinds of aid which used to be given to governments, which used to be given to some extent to NGOs. That entire situation has changed now. So whether it is UK or France or Germany or the US, now that variety of aid has shrunk. And instead of that, we have development financing institutions in the era of financialization. And there are also multilateral bodies like the International Finance Corporation, which is the biggest and the most influential, and which is actually an arm of the World Bank, but it is effectively, it's a huge institution in itself. And similarly, BIA in the UK, Asian Development Bank, US Development Finance Corporation, the German DEG, these are all relatively newer kinds of financial institutions which are supposed to have a development function, but actually they are purely focused on accelerating the growth of the private sector and the corporate sector in healthcare. Of course, they're not only in healthcare, they also operate in other areas, but healthcare is a major area of their operations. Now, these are a relatively new kind of institutions which governments, so the German government or the British government, taxpayers are giving money to their respective governments. And these governments have put together these kind of sort of international banking kind of agencies, which then invest money in countries like India in corporate hospitals. Not they don't have anything to do with, by and large, with public health systems, and definitely they are not charitable in any sense. So they put in significant, huge, large amounts of funds in the corporate sector in India. So this is something relatively new. And second, international private equity. And this is a whole new set of actors who are, as I said, they are in the shadows in many ways. So Blackstone, I mean, an ordinary doctor would probably have never heard about KKR or Blackstone or Carlyle, but these are huge private equity companies which have a global reach. They're of course based in the US, but they have a global reach, and they put in large scale funds into private healthcare in countries like India and of course across the world. And they have a very, very clear and very focused and limited objective of maximizing returns. And they usually, the way in which they operate, and I'll come to that soon, they are not in this for the long term. They are not interested in healthcare, developing the healthcare infrastructure in India or something. Maybe they say that on their website, but they basically come in, put in large scale funds, develop the sector for a few years, then make it a kind of a financially lucrative operation, and then just sell it off after a few years and exit with large scale profits. This is their mode of operation. They are not in this for 10, 20, 30 years. They're in this for a few years in which they want to recover major kind of returns, and that shapes the way in which those hospitals start functioning. So $5.5 billion or something like 45,000 crores is the estimated scale of their investments. And then there are venture capitalists. And these again are names which probably you may not have heard of. I had also not heard of these till quite recently. And they are not so much into hospitals, but they are in the other supportive sectors like health technology, telemedicine, biotech, medical devices, and also digital technology, digital health technology. These are the areas where they pick up startups and they invest in them. And I'll come to this very soon again. And these investments by private equity and by venture capital have multiplied in just 4 years. They multiplied by 15 times their investments. This is huge. So last time I had told you that overall foreign capital in the Indian hospital sector increased by more than 100 times between 2001 to and 2013-14. But within that, the even further acceleration, which we are now seeing in the last few years, is the expansion of private equity and venture capitalists. And venture capitalists, as you probably know, their whole modus operandi is of putting in certain high risk, but at the same time potentially high return investments, and then reaping very high returns, at least in some cases. Now, of course, the Indian private equity is also not far behind. So this is not just most of these are foreign, but there is also a significant component of domestic private equity like Reliance, Tata, Aditya Birla. These are well known, but also Chris Capital and True North, which are Indian private equity, which also is putting in significant amount of funds into private healthcare. And then we have these financial intermediaries, which is another peculiar and relatively newer kind of set of actors. Again, they are mostly operating in the shadows or not very visible. And Quadria Capital is one which I'll talk about, which is has played a significant role in certain major the growth of certain corporates in India, corporate hospitals, Piramal, Northern Arc, etc., etc. And I'll be talking also about the Abraj story, which is a fascinating story in itself. So the point is, these are the actors who are driving corporatization of healthcare. These are the financial actors who are driving an entire certain model of healthcare, of which corporate hospitals is just one manifestation, but actually it is much deeper and much broader than that. So these DFIs, which I already mentioned, this is a slide which I had shown last time also, but I'm repeating it because perhaps it may not have been completely well communicated last time. So these are the scale of investments. So BII from UK has 60 investments in top corporate and private hospitals in India. So the UK government is, basically fueling corporatization of healthcare. Now they are not doing this out of some sense of charity. They are firstly getting significant returns on their investments, and secondly, they're opening up India's healthcare sector to more and more corporatization, which is good for their economies, for the UK economy, for the German economy. So, for example, the German DEG, which we have studied as part of Sathi's study, is investing in certain specific corporate hospitals, but this corporatization leads to a growth in the market for pharmaceuticals. And as you know, Germany has many pharma multinationals. Growth in the need in the market for medical equipment like Siemens and so on. So it's a broader kind of impact. A ripple effect is there. And similarly, of course, IFC, which I'll be talking about in one of the next slides. So Apollo, Max, Fortis, Narayana, Manipal, you take up any major large corporate hospital, although they don't advertise it, but they're heavily invested in by DFIs and private equity, foreign private equity. Most of them are no longer, maybe they were made in India at some time, but today they are, it's more to take, they are these foreign DFIs are taking in India and raking in profits from their Indian investments. International Finance Corporation. So Oxfam has come out with an excellent report on this. Those of you who are interested, I would encourage you to read that whole report. And it just looks at IFC operations in Indian healthcare sector. International Finance Corporation is an arm of the World Bank, who has an explicit stated objective of promoting the growth of the private sector in low and middle income countries. Now they have supported various kinds of projects in India. There are 14 advisory projects worth more than $7 billion. And what kind of advice do they give? Why do we need somebody from Washington, DC to come here and advise us? So what they essentially advise is how to privatize public health facilities and through public-private partnerships. So right now in Maharashtra, the handing over of large public hospitals, basically district hospitals, in districts like Aurangabad and Latur and Nagpur is being done as part of a IFC supported project. So they are opening up the public health system to become privatized through this kind of quote unquote advice. This is the kind of advice that they're giving. And then they have, of course, direct investments totaling something like more than $500 million. And out of this, the biggest investment has been in Apollo. Apollo itself has received 7 investments from IFC so far, totaling more than $200 million. So Apollo has not grown because of just Apollo. Apollo has grown because of finance provided by IFC. You should be very clear. And the same is true for Max. The same is true for Fortis. And same is true for Manipal and many others. And I think Indra will also add further many more details. I have not gone into all the names and the details. And then they also have investments through financial intermediaries. And these are these other, I mean, I would call sort of shady characters who they produce nothing. You see, finance capital does not produce anything. Finance capital only shifts finance from here to there in the search of profits. And these financial intermediaries, they pick up capital, they access capital from different global sources, and then they put it together and they invest it in certain areas, and they act as sort of intermediaries to extract profit and maximize the return on these investments. So IFC has been operating through these intermediaries, which are completely often opaque. You go to their website, you'll not get any specific information. And many of them are actually almost 70% of these are domiciled, or they are based in tax havens like Mauritius or Singapore or Cayman Islands. So Cayman Islands, you cannot find out any details about them. So this is deliberate. This is not accidental. That's large amount of this finance, finance capital flows through intermediaries who essentially obscure the entire operation and make it almost impossible to ask questions or to find answer to questions. And we can discuss this further. We found this in the case of DG also, the German DFI and its operations, that they are operating through a intermediary called Quadria Capital, which is based in Singapore. उसमें सारे हिंदुस्तानी भाई लोग हैं. It's all basically is led by Indian professionals, but it's based in Singapore because that's a kind of a tax haven, and they are investing in significant scale in many of the big private hospitals in India, which you will know about. And these IFCs investments are concentrated in basically the big metro cities, and that's where they are putting it. So they are not facilitating access to care for rural people or for people in small towns or any such thing, or for the poor even in urban areas. It's very clear that they are financing the top end of corporate healthcare in India, and that's what they're making to grow even more. And yeah, these are just some snippets. So if you're interested, you can see there are many websites. If you just type private equity, Indian healthcare, you'll find. So Blackstone is a huge private equity company, one of the biggest private equity operators globally. And they have started putting in significant funds in the Indian healthcare sector. They acquired care hospitals, for example. And various other, there are a lot of such news items. And if you see the graph on the bottom, it shows that the scale of growth of private equity and venture capital investments in the health technology sector has grown by something like 150 times in the last 10 years, 150 times. So the scale of growth is really accelerated. And this is not just despite COVID, but even to some extent because of COVID. And then if we talk about venture capital, which jokingly we can also call it vulture capital, some of it at least. So venture capital is a peculiar form of capital which has a very clear objective. They look out for especially startups and relatively newer emerging technologies and companies which come up with some potentially promising technology, and they will put in large scale funds into that, and they expect that within a few years they will reap huge benefits. Not just so, this is one example, a Bessemer Venture Partners. Probably none of us have heard about this. They invested in certain Indian healthcare institutions and hospitals and made a 2000-fold returns in just 7 years. Now, this is unimaginable. This is this kind of scale of returns is unimaginable probably in any other sector. Below, I've taken a snapshot from another venture capitalist firm which is investing significantly in Indian healthcare, and its name is Relentless. and their stated objective is Relentless has an unwavering commitment to commercialize technology. I think that tells us everything. We don't need to hear much more about Relentless. So the name itself is there is no there are no boundaries. There is no sense of that there is some larger sort of social environment in which we need to operate. They have just a single and very, very focused objective of maximizing commercial returns. And when I talked about intermediaries, this is one important intermediary called Quadria Capital. Now, what does Quadria Capital make? Does it produce anything? No. Does it provide any service? No. Does it provide healthcare of any kind? No. What does Quadria Capital do? Does it have its own sources of funds? Probably no. So what they do is they, so international DFIs, large other private equity companies, Quadria Capital keeps scouting around and they attract funds from large global investors, and then they put those funds together, and then they come and invest those funds in countries like India. So NephroPlus, which has something like 450 dialysis outlets across India and South Asia. Vaxivision Eye Hospitals chain. Medibuddy, which you might have heard about, which is a digital health platform. Strand Life Sciences, which is a diagnostics company. Asian Institute of Gastroenterology, which I'm sure especially people from Hyderabad will definitely know, and others will also probably know about. A major institute. And Medica Super Speciality Hospital in Kolkata, which is one of the biggest corporate hospital chains in Eastern India. These are all, they have been heavily promoted by, and one can almost say they have been created by Quadria Capital, or not created, but they have actually, their entire growth has been heavily fueled by Quadria Capital. So these are these financial intermediaries. These are unique institutions which did not exist probably 30 years back, or if they were there, they were probably very small. But now they are really, and they also call the shots because they decide who is going to grow and who is going to be given these funds, and which kinds of technologies, which kinds of institutions will be actually, promoted, and which will probably not be promoted. So talking of these intermediaries, now I'll come to a interesting story, because it's a rather heavy material that we are talking about. So I think it'll be interesting for those of you who may not. Some of you might already be knowing about this story, and that is the Abraj story. Abraj was a company, a private equity company, more or less like an intermediary company, a child of financialization and also a driver of financialization in the healthcare sector. And they sold this myth of impact investment. Please mute your mic. And actually this entire, story of Abraj is a story of a rise and then a massive fall of this company because of huge financial fraud in the healthcare sector. And there's a book on this, which is called The Key Man. So if you're really interested in this capitalist fairy tale, it is a fairy tale which was manufactured and which then proved to be completely a disaster. I'll strongly encourage you to read this book called The Key Man. So who was Arif Naqvi? So Arif Naqvi was born in Pakistan, and he was a, sorry, just a minute. Go back. Yeah. So he started a small investment fund and then he shifted to Dubai. And in Dubai, he set up this firm called Abraj. And so Abraj, but basically what they used to do is they would um, say that we are going to provide, good quality healthcare to poor people in Asia and Africa, in South Asia, in India, Pakistan, or Kenya, or whatever. And whether it is Bill Gates or Prince Charles or so many other influential and also wealthy people, um, and firms, and also country governments, more importantly, whether it's British government or French government or US government, they would encourage them to make what they would call as impact investments. So impact investments are basically that you'll get a very good profit, supposed to be, and you'll also help poor people to get healthcare. And this was sounded like a very really like a sweetheart deal. ये तो बहुत ही अच्छी बात है कि हम पैसा भी देंगे, उसमें से हमको पैसा मिलेगा भी और गरीब लोगों को भी जो है कुछ हेल्थ केयर मिल जाएगा. And he sold this dream very successfully. And by 2017, Abraj had control of over $14 billion, which is a huge amount, in hundreds of companies around the world. He really spread this kind of empire. And these are all the people who invested in Abraj. So Bill and Melinda Gates Foundation, CDC from the UK, the US government, the French government, the International Finance Corporation, all of them invested hundreds of millions, not just millions, but hundreds of millions of dollars in Abraj. And Abraj had entered the Indian healthcare sector and was on the verge of taking over Care Hospitals chain and also certain other chains. And if they had not collapsed, perhaps they would have already been have had an even larger presence in the Indian healthcare sector. But उसके बाद फिर हुआ क्या कि then this entire they've set up a global markets health fund, and they kept attracting. This is how finance capital actually operates. The only thing is that probably Abraj overstepped certain boundaries, but actually it's a game of acquiring capital from different sources, investing that capital partly and partly, manipulating that entire capital in a way. So what he used to do is he used to pull funds out of some places and then claim that he's going to invest it somewhere, but he actually would not invest most of it. And he was actually embezzling a lot of those funds. It was actually not profitable, but he was able to show for years together that it was a highly profitable enterprise. This is how finance capital manages to create an illusion of profitability. And finally, he's now under house arrest in the UK, and he's probably likely to land up in jail in the US because of all of these, what we can call as financial crimes. But the Abraj story is not a unique story. So the Abraj story became well known because it was so large scale. But this kind of manipulation, speculation, and also what we can call as not very productive or healthy patterns of investing is common to a lot of the financialized sector. So I talked about some of the newer actors, the development finance institutions, private equity, venture capital, international finance intermediaries. Now, what are the newer processes? The most important and most visible process, which you've already talked about last time, is of course corporatization of healthcare. And finance capital needs partners, needs institutions where it can invest and reliably recover the returns on that investment. And for that, it needs large corporate entities. It's not interested in charitable hospitals. It's not interested in small hospitals. It's not interested in rural healthcare setups, because those are not the places where they're going to make profits. And also, when they're putting in millions of dollars or hundreds of millions of dollars, they want to put it in places where really they have the capacity to handle that kind of investment and also give the returns in a reliable manner. And for that, they basically need corporate entities. So this corporatization of healthcare is not just about growth of corporate hospitals, although that is the most visible part. So we all know about Apollo and Max and Fortis and Manipal, but it's extending far, far beyond that. And I'll come to that, and we'll probably in the discussions you can talk about it, how it is influencing the entire healthcare ecosystem. It's influencing small providers, it's influencing charitable hospitals, it's even reshaping the state policies in the health sector. It's a much broader process. So corporatization of healthcare is much larger than just growth of private hospitals. And of course, the second important impact of financialization is the rise of health insurance. So now, basically, as the state withdraws, health insurance is promoted in the same measure. So the state withdraws from provisioning, and people are basically said, okay, take health insurance. The rich and the upper middle class will pay for it from their own pockets. The poor and maybe to some extent the lower middle class, the government will partly subsidize it. But basically, government is not going to provide healthcare. Go and get health insurance and get your healthcare through whatever mediation of health insurance, because that is where the finance capital is entered. And it's a very rapidly grown. Well, health insurance market in India is about $90 billion or 7.4 trillion rupees, which is a huge amount. So this is much, much larger than, for example, our public health budgets. So, and government-supported health insurance is also playing a role in the expansion of health insurance. And now the third important aspect, which we briefly mentioned and we can talk about today further, is digitalization of various aspects of healthcare. And this is also very much a part of the ecosystem of digitalized healthcare technologies of various kinds, and links with financialization of healthcare. So corporatization, again, this is a slide which I had shown last time. I think this should really be a headline that, if the number of dollar billionaires in India, the largest number of billionaires are coming from healthcare, even more than manufacturing. It's something which should make us sit up and notice this, that what is going on? How have these billionaires become so rich? And many of them in a relatively short period of time. And their net worth is, 9.37 trillion, only the billionaires. We're not talking about the millionaires and the other, private sector. And so this is a clear and very obvious and major, offshoot of financialization is this growth of the corporate healthcare sector. And again, corporatization, again, we talked about this last time, but I'm just giving a few examples here. I think Indra can add many more. And if you read her article, you'll find many more details. But just for example, from 2012 to 2017, in just 5 years, just 5 large chains, Apollo, Fortis, Max, Care Hospitals, and one more, they increased their total revenues by 80% in just 5 years. Apollo's revenue in about less than a decade, it nearly doubled from 9,000 crores to almost 18,000 crores. And in Apollo, foreign institutional investors hold 44% shares, which is the controlling share. So Apollo is not an Indian company. Apollo is heavily invested in by international finance capital. Similar is true for Fortis. Similar is true for Max Healthcare, which doubled its revenues in similarly less than a decade. And something called KKR. KKR is not your IPL team. This is a major global private equity firm. They have acquired 50% share in Max Healthcare. And then after taking this share, just within 4 years, they reaped a 5-fold return on their investment, 500% return in just 4 years. And they exited. That is how private equity operates. So they're not interested in what is happening to the hospital, what is happening to the patients, what is happening to the sector, how are people benefiting or not. They're only interested in coming in, putting in large investments, inflating the cost, the price of that, or the value of that particular enterprise in the market. And once it is grown to a certain extent, then selling off their stake and exiting. That is how finance capital operates. So their share value in just 4 years, it grew from 80 rupees per share to something like 400 plus rupees per share. That is how they, made this huge kind of what can be called a killing. And what are the features linked to this financialization? So this is just like a kind of an overview. What is, how do we, understand financialization? It's opaque. It's often non-transparent. It's often their investments are routed through intermediaries. Even governments operate through these shady and not completely non-transparent, often financial intermediaries. It's volatile because capital can enter one day and exit the next day. It can shift wherever it, and we know that in 2008, the whole world saw how finance capital created this huge crisis, which had, of course, affected the West more, but it affected the entire world in various ways. And it's prone to recurrent crisis because it's not regulated. It's hyper extractive. It's unaccountable and breeds undemocratic behavior of governments also. It's very centralized and it leads to concentration of money and power. That is a feature of financialization. It's remotely controlled. So the people who are taking the decisions about which hospital to set up, which hospital to expand, which hospital to shut down are not sitting in India. they're sitting somewhere else, and they have no relationship with the society or with the population who's going to be accessing healthcare in these hospitals. So it's like completely remotely controlled and it's globalized. It's highly globalized. But this globalization is in a very inequitable manner. So I think I'll pause here because we've probably covered quite a bit of ground. I'll just end by making a medical metaphor. I hope that this metaphor is not taken too literally. But I thought that for an audience of many doctors, it may be, and also non-doctors will appreciate it, it may be interesting to look at this metaphor. So financialization is a stage of capitalism. And it's been called, there's a book on this, which is called The Cancer Stage of Capitalism. So there are some similarities between cancer and the kind of financialization that we are seeing right now. It's characterized by unchecked and rapid growth, very rapid growth, and it's unchecked. It just proliferates. There's loss of regulation. So finance is supposed to be subordinate to production in a balanced economy. So obviously, manufacturing or any other service sector, they need finance. So logically, finance should be supporting production of goods and services. But here we are seeing the sort of reverse starts happening. So finance starts driving the other sectors or shaping the other sectors in its own interests. And there's a loss of regulation of this finance. Who can regulate this international financial, private equity or so on? It's very difficult. And this finance capital is parasitic on other parts of the system, just like cancer is parasitic on other tissues and organs. It can metastasize and colonizes more and more areas, and it culminates in destroying the system, like any aggressive cancer. So, and we've seen that in the 2008 financial crisis. So if it is not controlled, it can really destroy and damage the system. So I'll pause here because I think this was quite a bit of ground that we covered, going into a little deeper description and analysis of uh, financialization. The second part, if we have time, is about digitalization. Okay.
Thank you, Dr. Abhay. I have a list of questions that I have copied from. So I'll just read them out to you and maybe you can answer them. Does that work?
Yeah, that's okay.
So Ravi Vicky has asked, what are your thoughts on public-private partnership in the healthcare system?
Okay. So, yeah. So maybe before we go into the questions, Indira, do you want to add something to this, like brief description, necessarily very brief description?
Yeah, can I take just a few minutes?
Yeah.
To add a little bit, of course, I know this has been a really dense presentation, but the paper Dr. Abhay Shukla referred to was a 2017 paper. So we were thinking of actually updating it in many ways because, the extent of financialization has actually increased. So, I mean, I'm also trying to answer some of the questions from the last session that Gayatri shared. But as part of corporatization itself and financialization, it's interesting to also see who all are now coming into the health sector. I mean, for instance, um, uh, in the past few years now, I mean, in North India, especially if you see, there's a very big newspaper group called Amar Ujala, right? Amar Ujala has been setting up hospitals, small and big hospitals. It's a newspaper chain, very popular newspaper chain, right? Then there is a company, there are Paras hospitals, and I tried to look up who is setting up these Paras hospitals. Paras again is a very big dairy group. It has made its money from selling milk and milk products, much like Amul or these other companies that we have had in India. So we have a range of Ujala Cygnus hospitals. Cygnus, I think, was a medical equipment manufacturer or whatever. And the latest entry now is the Bajaj Group. Bajaj, which is known primarily for manufacturing two-wheelers and uh, um, other consumer items and electrical items, right? It's being advertised in a very big way. If you remember the Hamara Bajaj scooter, now Hamara Bajaj is into setting up Hamara hospital kind of. So one is to understand, one is finance capital, which is being talked about, but this you can call it association, you can call it collusion of various business interests, and for the expansion of businesses, then you need finance, and how these interests, uh, um, for all of them now, healthcare is a very lucrative opportunity, right? And this, we need to remember, has been actually promoted as a policy measure by the governments itself. In the 1990s, 2000, it began as presenting India to the world as a big site for medical tourism. And so, promoting medical tourism also itself as how it has contributed to this kind of growth of the private healthcare sector. You see, because some people here had put questions how these are influencing policies. These have not simply happened. These have all happened due to a range of policy measures that have been taken. The other thing I wanted to add to the list of investors, if you take the case of Sayadri Hospital in Pune, Sayadri is a relatively smaller regional hospital chain which has moved from several private equity investors. It was started initially by a neurosurgeon, by a doctor, and some other wealthy individuals in Pune. Now, the latest, if you see, the owner of, the owner in the sense of the biggest investor is the Canadian Teachers Pension Funds, right? The teachers' pension, the Ontario, sorry, not Canadian, Ontario Teachers' Pension Funds from Canada, who have now bought a very big stake. And so, effectively, they become owners of the Sayadri hospitals. Sayadri is still nowhere near as big as Apollo and Narayana and Manipal and so on. The other new entrant is a Swedish hospital chain called Medicover, which is actually setting up hospitals, buying several hospitals in India. So if I were to update it, then this kind of ownership and investment has actually only increased. So corporatization and financialization also bringing in the what would be called a lot of global actors now, right? What would be called multinational hospital chains. So that is one I wanted to draw attention to. The other thing I just wanted to say was uh, the larger economy itself in India, I was trying to look up, and the economists warn us about India's domination by international capital, particularly by international finance, right? So, if you look at it from that viewpoint, so international finance, I mean, that is something I also referred to, but infrastructure, and in that healthcare has been really promoted in a big way. And if you look at some of the recent Niti Aayog documents, right, one of them Abhay has already referred to, investing, the healthcare as a very big business opportunity in India. That is, soon after the COVID pandemic, that was the document brought out by Niti Aayog, how the range, the kind of business opportunities in healthcare that India offers, right? So yes, it is influencing our health policies in a very big way. And this document itself, healthcare as a big business opportunity, was also prepared not by public health researchers, not by bureaucrats and other officials sitting in the government or public health professionals like us, but by many of these business consultancy organizations. There are four big business intelligence organizations: McKinsey, PwC, KPMG. These are very actively preparing several Niti Aayog reports. You can go look up the Niti Aayog reports, and they are very active. So is the Gates Foundation, right? So yes, there is a lot of influence. We no longer have the Planning Commission, and it is Niti Aayog. And in Niti Aayog, here in Delhi itself, we see that all the business consultancy organizations work very actively, sit in Niti Aayog, and are preparing all kinds of reports, including healthcare reports. The last point is what to watch out for. See, this kind of private equity itself, one can trace it to 2000 and following that, which were policy measures which were promoted by World Bank and IFC. But now what is called a new kind of a financing mechanism is being promoted. Again, Niti Aayog has a report on it, which is called blended finance. So basically combining government, whatever little government financing government allocates, along with that private equity, but also uh, philanthropy now also, where philanthropy itself being made into an investment. And so philanthropy itself to fetch returns, what is being called blended finance. So again, there is a Niti Aayog report, but this is again the whole change among development finance institutions and among policy makers itself globally, who also advise Indians policy makers, is to actually promote private sector growth. So in that, there is no conspiracy. There is a conscious effort that yes, the private sector needs to be promoted, and these are the vehicles, and it has been happening for the past 2-3 decades, right? So I'll just stop there, and I won't get into digitalization. And it's a different thing. We can do that later on. Yeah, that's it. Thank you.
Yeah, thanks, Indra. I think that was very useful. And maybe you can come in again.
Yeah, sure.
During the discussion.
There are a lot of questions. So
yeah, there are lots of questions. And in fact, I'm feeling really scared looking at all these questions. And very diverse kind of questions. So let me try to take some of them. So Indra, I'll take the easy questions. You take the difficult questions. Is that okay?
Well, who decides that? I think. How did you arrive at that? Anyway,
okay. I'll start with some of them. Okay. So the first question is about public-private partnerships and how do we view public-private partnerships? So of course, this is a big area where perhaps already we know something about it. But the whole idea about public-private partnerships is that public institutions like a public hospital or a public health facility of some kind is used as a platform to expand private business and private business of some kind. So it may be outsourcing something in that public hospital. It may be handing over the public hospital to a private operator, or it may be entering into some sort of other arrangement where the land or the space or the facilities of that public hospital become available to a private operator. But the main point is that a public facility or a public service is, in a sense, opened up as an arena of investment for private operators. And the argument given is that this brings in finance, and this brings in sometimes maybe technology. But in most cases, what we see is that actually the government ends up paying more to the private operator than what it would have spent if it had operated the facility on its own of course, in an efficient way. And secondly, that people, their access to care, which is usually, at least nominally, people have access to free care or very highly subsidized care in a normal public health facility. Once it goes into a PPP mode, there are a whole range of problems that are created in people's access to care. So, the private operator, for example, referring to a recent study which has been done by my colleague Shweta in two major municipal corporations of Maharashtra, Mumbai and Pune, looking at PPPs. There's something like 40 PPP arrangement MOUs which have been done by the municipal corporations in just in the health sector. And many of these involve the public hospital being turned over or handed over either in full or in part to some private operator who is almost always politically connected. And then they start charging fees for a service which was earlier supposed to be free. And even if they have some arrangement on paper that they'll give some percentage of free care to poor patients, it almost never works. And so effectively what happens is that the public hospital or the public healthcare facility starts functioning like a fee charging private healthcare facility. So this is one important type of PPPs. Another important type is where the government pays, people still are supposed to get the service free, like let us say ambulance services, which across states of India have been handed over the so-called 104 model. But there, the government actually ends up paying huge amounts, much, much more than what it would have cost if the government had operated itself. So in Maharashtra right now, the contract for the next 5 years of 104 ambulance services has been negotiated with a particular private provider at the cost of 10,000 crores. Now, in 10,000 crores, we could have bought so many ambulances in the public health system, paid the salaries of drivers and other staff, and run it quite efficiently. And at the end of 5 years, the government will have nothing in hand. If we had purchased our own ambulances after 5 years, at least many of those ambulances would still have remained with the government. This, after 5 years, there'll be nothing, zero, zilch. Everything is taken back by the private operator. So, I mean, these are just a couple of examples of how public-private partnerships generally don't serve the public interest very well. They generally tend to serve private interests more. National health policies. Yes, obviously, and I think Indra has also mentioned it again. Please read the Niti Aayog document. If you, are fond of horror stories, then, you'll find it interesting. So, so the whole document, which is published in the middle of COVID, it was just before the COVID second wave. And the entire document doesn't have a single sentence about regulating the private sector. It doesn't have a single word about how the private sector overcharged patients. It just says that the government should invite private equity, international and domestic capital to invest and privatize the Indian healthcare sector more and more. This is a huge business opportunity. People are willing to pay for healthcare, and private operators can make huge profits out of healthcare. I mean, I'm just summarizing it. So, it's very clear that the government is operating under heavy influence of such advisory bodies like Niti Aayog. And the whole way in which PMJY has been presented as a solution, through health insurance or health assurance schemes and various other, that's a whole topic in itself. So I'll not go into that, but obviously this has a very strong influence on health policies by the government and also at the state level. Raising a chicken for slaughter, absolutely correct, a very good analogy. So you fatten the chicken. So obviously in the short term, so finance capital is a lot about short termism. So in the short term, it looks good because the value has increased of that particular hospital chain or whatever. But actually it is being bled, internally. So there's an excellent book by a US author called These Are the Plunderers. It's written by, just a second. It's written by Gretchen Morgensen. So I had the good fortune of meeting Gretchen recently, last year when I went for a visit to the US. And she has written this book about finance capital, particularly private equity. And the subtitle is How Private Equity Runs and Wrecks America. And there are 2 chapters on healthcare. And it's called Private Equity and Healthcare, Capitalism on Steroids. And she shows in case after case how private equity is now entering. And US is a relatively more regulated environment. But even there, private equity enters into a hospital chain. Maybe previously it had been a not-for-profit or something. They buy it, they invest in it, they increase its value to some extent, but they also bleed it dry. They sell off its land, they sell off its equipment, they do various other things, and they bleed it dry internally, but externally it looks like something profitable. They inflate its share value, and then they exit with a large amount of money and leave that enterprise in very bad shape. And the communities which are being served by that hospital are the biggest sufferers. So that's another example of this raising the chicken for slaughter and then cutting it and exiting with the whatever. Apollo provides some kinds of healthcare which is not available to people otherwise. Yeah, but the problem is that AIMS could have provided and probably still does provide. I'm a graduate and postgraduate of AIMS. I mean, in the 1980s, 1990s, there was Apollo was nowhere in the picture. Anybody with a serious healthcare problem, including even the top politicians of the country, used to come to AIMS. So we neglected AIMS and we allowed Apollo to grow. So that's why now we've landed up with a situation where certain kinds of high-tech medical care is more available in Apollo and not available in the public sector. But if we had opted for a different path, which we can still do, then we would, promote these high-tech kind of treatments and so on in large public hospitals if they are properly funded. So there's no reason why, only Apollo can give this kind of care. But of course, today that situation, we've landed up in that situation. So there needs to be a transition. It's not going to happen in one day, but let's, we can discuss that further. Then there's something about how increasing private equity increases the cost of healthcare. And that's a good question because it's actually a little complex because there's also a market competition. So, so what is actually done is, and this is where technology plays a very, very important role. So capitalism has the seduction of technology, and that is what actually seduces all of us, because technologies which are needed and technologies which are perhaps not so much needed, they are brought in by this private investment, and then they are offered at a certain cost. And that starts pushing up the overall cost of healthcare. Besides the fact that there is profiteering, besides the fact that within that treatment, the prices are being jacked up a lot. I mean, for example, if a private hospital, we've done this study in Maharashtra, is selling drugs to patients. Many private hospitals do this. So, the cost at which the drug is, bought by the hospital, maybe 10 rupees, and the cost at which is sold to the patient is often 50 rupees, or consumables may even be 100 rupees. So this huge profiteering is going on, which obviously pushes up the cost of healthcare in different ways. And there are targets, there are investment targets, which, push these hospitals to, admit more patients, perform more unnecessary procedures, perform more investigations, prescribe more expensive medicines, etc., etc. I think many doctors will be familiar with many of these things. How to approach telemedicine and increasing health technologies, and yeah, venture capital plays. So it's true that in today's environment, many of these newer technologies are being pushed by or promoted by venture capital, but there are other models of technology development. For example, the Cuban model. So Cuba has some of the most advanced healthcare technologies in the world without private capital. It's a very small country and it's not a very rich country, as you probably know. And yet they have developed some of the most innovative vaccines and various other kinds of healthcare technologies. So again, the point is that if there is a will, and as you probably know, many of the COVID vaccines were actually originally developed, including Covishield, were actually developed by public, institutions like Oxford University or, some other public, medical research bodies, even ICMR for that matter. So if public bodies can be encouraged and supported to produce those technologies, then we don't have to rely on venture capital. And at the same time, of course, we have to choose between what you're calling good technology and bad technology. And that's a big discussion. I think Indra will have more to say on that. But yes, technology is also very central to this discussion. And technology choices are also very important. Uh, I think that covers at least one set of the questions. Anand has asked that we know that privatization led to the growth of tertiary care. What does financialization do to the nature of healthcare? What are the changes that we can think about? So, if we examine the contract between the doctor and patient hospital, uh, yeah, so hospital and patient change with financialization. Does this reflect what is happening in other countries? So, just like privatization and commercialization led to the growth of the private hospital sector and private multi-speciality hospitals, and yes, also secondary and tertiary care. Financialization is leading to the massive growth of health insurance, to the segmentation within the healthcare sector and promotion of a range of different types of um, technologies and a sort of segmented industries, which include, so for example, eye care becomes an entire chain, or in lab investigations get set up as an entire separate chain, or digital health, certain kinds of new industries develop. um, so these are all the kind of developments that we're seeing in the phase of financialization. And uh, yeah, probably there'll be others also, but and here it's fragmentation of the healthcare system and fragmentation of provisioning of healthcare, which increases more and more, and the patient is kind of caught in a trap where the patient has to negotiate multiple different kinds of providers and multiple different kinds of agencies to get healthcare, rather than it being integrated under a single kind of system. So I think these are some of the there are more questions also. They keep coming in. So what should we do? Gayatri, should maybe Indra, do you want to answer some of the questions, some of the other questions?
Yeah, I think that today we can keep it for answering questions and discussion, and then plan
Okay.
another session for digitization, because, and I hope that Indira will also have time for that, because these are all questions that are coming out organically, and maybe more learning from that, and then less overwhelming if we take the next session, if that's okay by you.
Yeah.
Yeah, I agree. I don't think we can take up digitalization now. It's already 8 o'clock and we all have to,
Yeah.
we can't continue. And but if I can, yeah, quickly add to, because there's a really very interesting questions which which need to be discussed, particularly among doctors. We feel, because we try to do a very small study, and I mean, my personal view is that, unless the doctors working in these hospitals understand what is happening, and unless they say what is happening, it is next to impossible for researchers to go and get this out. It's impossible to go to a corporate hospital and talk. We've tried several times. I mean, I'm placing this, because somebody has said here that Apollo at least provides some care, and so doctors are not able to point this out. It is true. That's because we have a very bad public health system, right? But there are, I mean, it's not just public health researchers. I'm sure doctors are also concerned, not just because what it is doing to patient care, but what is happening to the doctors working here. The doctors are all employees of these hospitals, right? That is one of the studies. So the experiences of the doctors here, and how are they being able to take ethical decisions, because the few doctors, the 20, 30 doctors we spoke to, they all did say, yes, there is pressure on us. And the pressure if you look at the corporate hospital structure, the finance department and hospital management, why has it become such an important discipline now in public health? You know, with Tata Institute and all, hospital management courses have become extremely popular, right? Of course, we do need management of hospitals, you know, but how do you manage? What would be the goals of management in public hospitals? What are the goals of management in corporate hospitals? Why is the chief financial officer in corporate hospitals so important? It's become a very important role, right? And the regular weekly, monthly meetings among doctors and the hospital management and the finance officers are very important meetings. What happens in those meetings, what kind of pressures are put on doctors, one needs to understand. I mean, there's a doctor here called Dr. Anita Bakshi from Apollo Hospital, who's written a book about her experiences. She's working in the Indraprasth Apollo Hospital in Delhi. She's a pediatric surgeon. She has one or two chapters on the corporate mafia in medicine. And she describes her experiences and she talks of the targets hanging over the heads, right? So it is very important, I think, where doctors also who are working in these hospitals understand what is happening. Now, from our, how does private equity push up cost of healthcare? I would just like to quote from a witness seminar which we did as part of our study, where we had a hospital manager, Abhay would remember, who said, what is the source of money? What is the source of profit in a hospital? How is surplus value generated in a hospital? Right? And he said the source is the cost of care. The source is the patient, right? So it is, and so you know, if that gives you an idea of how profits, making profits and profiteering for the hospital, profiteering, making profits for even the company, even the hospital company. What is the source of money there? It is not just medicines, procedures, yes, they are one source, but all that is extracted from the patient. Every single naya paisa is extracted from the patient, which has to pay the doctor's salary, the nurse's salary, which has to also pay the profits of the shareholders. And if you have a private equity investor, a big investor, it has to pay for their profits also. So this hospital manager was very clear, right? And he said, look at what are the goals of corporate hospitals? What are the goals of hospitals like Apollo and all the corporate hospitals? I mean, we should not take just the name of Apollo, right? Apollo started it, but we now have many, many more. So, you know, Apollo is not the only kind of wrongdoer here, or whatever we may choose to characterize Apollo as, right? If you look at their business reports, they are all about increasing revenues by 100%, increasing profits by 200%. These are the kind of financial goals that hospitals have set for themselves, right? And what does that then do? It's very, very essential for doctors to also think about ethics, about how are they in a situation to take ethical decisions about patient care, about the treatment is one thing. Then does this I mean, so that is one big area, you know, which could be discussed later on. If any of you is working, or if any of you is working, or if you have colleagues working in corporate hospitals, after a point, what is going to be the employment? Where are doctors going to be employed? You know, with a shrinking public health sector, right? What options do doctors have? All of this, which we have discussed in our paper, right? It's becoming so difficult to set up charitable hospitals also. What is the source of money going to be for smaller hospitals, for secondary level hospitals? These are all questions which I'm sure doctors, young doctors, are grappling with. Does this reflect what is happening in other countries? Yes, India is, of course, corporatization of this kind has been written about in Malaysia, in Australia, and the biggest example of corporate healthcare is, of course, the USA, from where it has been exported to many countries. You see, in fact, I mean, going back to Dr. Pratap Reddy, when he set up the Apollo Hospital in 1983, the first corporate hospital in the country, he set it up here with the very clear notion of providing the kind of specialty care in the US model and the whole managed care model itself. That was the very purpose in starting that kind of a hospital. And then how the government stepped in and some of these business models in India, the Apollo model and the Narayana models, have been very well studied, interestingly, by the Harvard Business School. As you know, how to be able to provide healthcare at such a low cost. There are very, I mean, this is a very interesting how Harvard Business School has studied these models and how are they able to provide. Uh, uh, so I think I'll stop. So, yes, it is happening in other countries too. It's been talked about in Australia, in Malaysia, in this part of the world, and in Latin American countries, it was promoted. In several African countries, the IFC promoted, Apollo and Narayana setting up hospitals. Narayana has some offshore hospitals in Cayman Islands and all. So all that one needs to understand. And yes, the profit for global finance from healthcare is being paid by all of us. That is the only source of profits in hospitals. As I mentioned, this we really need to understand. Uh, there could be other models, but tell me how much time we have, because it's already 8 o'clock. I know the session was from 6:30 to 8.
Yeah. So I think we should try to answer the questions in this session, the remaining questions. So, so one is, of course, Sayantan has asked, do you think that the profit-making margin is unlimited in this financialized healthcare sector? What are the natural limits, market cap to this bubble, and what limits can be imposed by regulators and civil society? An important question. And actually, that is one reason why I started with the Pandora's box, and also by saying that at the bottom of the box, there is a gem called hope. Because when you start talking about financialization, it's actually quite natural to feel overwhelmed. I at least felt quite overwhelmed when I initially started studying all of this. और यार ये तो इतना बड़ा है और इतना मतलब it's so huge and so apparently unregulatable that how do we deal with this entire thing? So I'd like to add, and Sayanta, this is not a direct answer to your question, but it links with that, because I think we should have one session totally dedicated to what are the practical strategies by which health activists and medical professionals can deal with financialized healthcare and offer alternatives. So what are the alternatives at the policy level, and what are the practically doable, activities that we can do at some level, at least as a collective. So let's have a separate session on that, because it will be difficult for me to just give a 1, 2, 3 kind of answers to that. But having said that, the giant of financialization has feet of clay. उसका बेस जो है ना बहुत स्ट्रांग नहीं है, वो देखने में बहुत बड़ा है. हमने 2008 में एक बार देख लिया उसका क्या हाल है. It's a giant with feet of clay. It is very vulnerable in certain ways because it's unable to regulate itself like a cancer. And therefore, profit making, of course, margins, they get partly corrected by the market and competition and so on. So obviously, if some hospital starts charging 10 times more than other hospitals, it will not remain in business. So वो तो market का अपना एक limited सा logic रहता है. But I think more important is that society, at some level, this model gets detached from society. There is no care that remains in healthcare, or the component of care becomes less and less. It becomes more and more technology driven and finance driven. And as a result of that, जो मैंने पिछले सेशन में सेकेंड मूवमेंट की बात की थी, पोलानी का फर्स्ट मूवमेंट और सेकेंड मूवमेंट, वो सेकेंड मूवमेंट हो सकता है और शायद उसकी शुरुआत भी हो गई है. And that will be when people start raising questions. And the medical profession is also involved. It cannot be done by patients alone, and it cannot be done by doctors alone. it will require some kind of broader alliance where patients raise issues about the costs of care, the rationality of care, and doctors support them by saying that, many of these things are actually not required. So the first level has to be about questioning unnecessary procedures, admissions, medications, investigations, and so on, which are inflating the costs of care. And that is an area where we have a reasonable degree of medical logic on our side. But as I said, ये अकेले patients भी नहीं कर पाएंगे और अकेले doctors भी नहीं कर पाएंगे for different set of reasons. But if both are together, we can build a very powerful argument to say this is wasteful and it's also exploitative. We're wasting resources on doing things which are actually don't need to be done. I think that's a very powerful argument. That's one argument which we should start raising. The second is that in regulation, costs of care and the standardization of costs of care should become our fulcrum. और आप लोग ऑलरेडी मेरे ख्याल से ज्यादातर लोगों ने ऑलरेडी उस पर अपना सिग्नेचर भी दिया है, जो FEH ने जो टेस्टिमोनियल बनाया है. सो इट्स लाइक द, टू पुट इट इन अ लाइटर वेन, जैसे रावण की जो नाभि थी ना, तो उसमें एरो डाला तो फिर सब कुछ उससे कंट्रोल हो जाता है. इफ वी आर एबल टू रेज द इशू ऑफ रैशनलाइजिंग एंड स्टैंडर्डाइजिंग कॉस्ट ऑफ केयर, a lot of this, at least a discourse can open up about what is rational costing of care and what is inflated costing of healthcare. And that is a discussion that we need in this country now. It's overdue. So I think that is again an area where patients' rights activists and socially oriented healthcare professionals can come together and start talking about, of course, I mean, if you're giving a service, you're performing a delivery or doing a cesarean section, there is going to be some cost. So what is the rational cost of care and what are the inflated or irrational, elements of healthcare costing? This is something which we should put on the agenda. And that will be another area where, जो आपने पूछा ना, limits imposed by regulation and civil society. And then we ask governments to start bringing in some kind of standardization. But even before standardization, start with transparency. अरे मार्केट का तो बेसिक प्रिंसिपल है कंपटीशन, और कंपटीशन का बेसिक प्रिंसिपल है ट्रांसपेरेंसी. How can you have competition without transparency? So why are not hospitals making available their rates for people to know so that they can compare and decide? This is also another powerful argument that we can raise. So I've just given a few examples of some areas where we can start challenging this discourse through a very logic-based and sound medical plus social logic-based kind of arguments. So I will not go into further detail, but these are just some quick comments. Suresh, yeah, both your points are completely valid. The PPP model in the water sector has been really problematic, and yes, we need to counter financialization, both conceptually and practically. So we need to start also lifting up alternative models and alternative approaches. And wherever public health services have still continue to function reasonably well despite all these situations, those models need to be highlighted. And we also need to bring to the fore how people, अब जैसे हमने कोविड के पैंडेमिक के दौरान जो प्राइवेट हॉस्पिटल्स के बिल्स का ऑडिट किया, and we got private hospitals to return certain amounts to patients, of course with the help of the government. That was something pretty unique. So, and it also showed something larger, कि if people get mobilized, private hospitals can be put on the defensive. And so we'll have to raise these kind of issues which have a social kind of appeal. And I can tell you 90% of people in this country will support, for example, rate regulation in private hospitals, if they're given a genuine choice. Because so many people have been affected by these things. They will support rationalization of healthcare and elimination of unnecessary all aspects of healthcare which is going on, and so on. So we need to definitely raise these kind of models. I think yeah, we've taken care of many of the questions. So it's already 8:10.
Yeah. So just quickly, I wish to just add very quickly, because there was a question here about, would removing the profiteering from healthcare be, there was some question here about, healthcare as a profit-making activity. Yes, that is primarily a problem. How to provide healthcare, how to organize healthcare. I mean, there was a reason why in the why 100 years ago, almost, early 20th century, there was the whole idea of comprehensive healthcare as a responsibility of the state. The whole idea was built up and was promoted and implemented, right? Now in this context, we also just need to keep in mind there's the whole non-profit private healthcare model. You see, earlier, I mean, there have been good what we call trust hospitals or charitable hospitals. Now they have been impacted by this kind of profiteering, right? So what are the areas in which the smaller not-for-profit private models, I mean, the kind of work that many doctors have been doing in smaller towns, and we know there are a lot of these kind of hospitals also running. They may be religious affiliations, they may not be, we don't know, but we need to also keep that in mind. The whole the non-profit private healthcare hospital model has simply that which provided the secondary level care, the primary level care. And what hospitals like Sitalangi are also doing, right? The whole tribal health initiative, and we have all that. What do they have to offer? That also needs to be just kept in mind. Yeah, I will stop there.
So I hope we covered some ground today, some more ground. And at least maybe all of us got a better appreciation of ये पूरा है क्या चक्कर financialization का. There is much more that can be said and can be discussed. But again, I want to leave you not with a sense of desperation or confusion, but with the fact that any problem which has been created by human beings can be solved by human beings. Let us sort of proceed with that confidence. And the fact is that across the world, and this is an interesting thing, just like financialization is globalized, the critiques of financialization are also becoming more and more global in nature. And when I was in the US, I mean, a few months back, I could see प्राइवेट इक्विटी इन हेल्थ केयर कितना बड़ा इशू यूएस में बन रहा है. मतलब वहां पे भी लोगों को ये समझ में आ रहा है कि ये मामला गड़बड़ है, इसमें ना लोगों का फायदा नहीं है. And like I shared that book with you, and she's a best-selling author, Gretchen Morgensen. And so global एक इसको लेके डिस्कोर्स धीरे धीरे बन रहा है. For some reason in India so far, even in the progressive health movement, I would say, so far we have not talked much about financialization. And I don't know, for whatever reason, maybe people have not put in that much effort so far in trying to understand it. So maybe in the next session, all of you can suggest how we should do it. Digitalization and financialization in healthcare is something which we should definitely discuss, because it's a partly answering an Anand's question, what are the technological changes associated with financialization? Digitalization is a big one, and corporatization is another big one. These are the unique and or whatever, जिसको बोलते हैं markers of financialization. So we should,
for the business interest, to emphasize what Abhay is saying, big data is the big seducer now. You see, digital epidemiology, big data, and there is, as you all know better as doctors, there is immense data in healthcare. The private
we'll
data
cover
of
that.
patients, the
Yeah,
private data of patients. So that is becoming
Yeah.
another entry point then for capital and for corporate interests, business interests, right? Yeah.
So maybe it will be good if next time we can discuss about digitalization and financialization in healthcare. And after that, then we at least try to have one session about the practical implications and alternatives. And that will be the most interesting session. And and there, I think various people will contribute. And like myself and Indra can be there, but and maybe we can also invite one or two other resource persons. Let's think about that. So it's like but I think it is a good exchange today. Maybe Gayatri, Anand, all of you can also tell us whether it was useful, and we can maybe plan the next session. And if there are any other further questions, or if you have, we'd like to have some more material, we'll be happy to, share that also to the extent that we have access to that. So Gayatri, can we wind up?
Yeah.
Sham will do it for me. Thank you.
Okay.
Thank you so much, both of you. Honestly, it was really valuable, and the chat has been absolutely buzzing. Even some of our WhatsApp groups have been buzzing in this time. So I think at least for me, what is very clear is how do we take this forward? This info, this knowledge, this thing cannot just be limited to this little group of people. We have to spread the word, as you were saying, Dr. Abhay. Like, more people need to know about this, and I think it was superb. I think we have at least another book title out of this. The Giant of Financialization has feet of clay. That was a knockout punch. But thank you both so very much. Thank you so much, Indra, for spending your time with us. And hopefully, we look forward to seeing you around next time as well.
Yeah, sure. Thank you. Thank you for
Okay.
calling
Thank
me,
you.
inviting
Thanks
me.
a lot.
Yeah.
Thanks all for joining us.
Yeah.
Goodbye.
Yeah.
Okay.
Bye-bye. Bye,
Bye.
everyone.
Bye.
Yeah. Bye.
Thanks, Ravi. Yes, we'll continue these sessions as much as possible.